Welcome everybody to Wednesday at NTW. We're joined now to listen to DOACs and extremes of body weight by Professor Raza Alikhan and Dr. Tristan Groves. Dr. Alikhan is a consultant haematologist in haemophilia and thrombosis at the University Hospital in Wales, in Cardiff. As many of you will know, he has been involved in a lot of work in BSH, but also in phase 2 and to phase 4 anticoagulant clinical trials since the late 90s. His current research interests include the identification of risk factors and outcomes associated with anticoagulation and related bleeding. And we're very, very fortunate to have him here today. And he is joined by Dr. Tristan Groves, who is the lead anticoagulation and thrombosis pharmacist for Cardiff and Vale University. University Health Board. His research interests include effect of extremes of body weight and renal function for patients treated for AF or VTE with DOACs, and the potential for drug interactions with systemic anti-cancer therapies and anticoagulation. So we really do have an amazing lineup this morning. Both Raza and Tristan are very open and would welcome your questions. So please do post, ideally in the Q&A, because it's easier for me to see, but if not in the chat, please do participate. And if you can hear background while I'm talking, I apologise, it is a dog snoring. But anyway, without any more to do, let me pass over to Dr. Raza Alikhan and Dr. Tristan Groves. Thank you very much.
Joe, good morning. Thank you so much for the invitation to speak. And once again, thank you for everything that you do for Thrombosis UK and all the hard work that you put into Thrombosis Week. Thank you to our audience for joining us today. I have to say I'm very fortunate to be part of a fantastic multidisciplinary team made up of doctors, nurses, pharmacists, and a great lab team. And we, over the last 5 or 6 years, have established a regional laboratory service which has facilitated the introduction of safe use of direct oral anticoagulants to a widening population. And I'm very fortunate to be able to introduce my colleague Tristan, who's a national and international expert in this field. He's been invited to give talks all across the country and in fact globally, and there are some great presentations that he's recently given at ISTH. And so he's going to share with you his experience in a specific area, extremes of body weight, high body weight, low body weight, some of the research that he's done, and then we're going to have a conversation about some sort of practical aspects of how we manage patients at extremes of body weight. So great pleasure for me to introduce Tristan, and I'm going to sort of try and get out of the screen. Thank you very much, mate.
Thank you. As sort of Joe and Raz have said, we're very open to having questions as we go along. Raz has just disappeared, but he is still here. So if you hear a voice from the ether, that's probably himself. So as Raz said, what we wanted to discuss today is looking at how we can safely use DOACs and should we be using DOACs in patients with extremes of weight. Initially focusing on those patients with venous thromboembolism, and then looking at some of the research that we've done regarding atrial fibrillation as well. So going forward, what are the considerations when we're thinking about extremes of weight? Why are we even concerned that DOACs might be an issue? Well, theoretically, as I'm sure you all are well aware, that DOACs have a fixed dosing regime. We can't just increase dose just because we happen to have a very large patient in front of us. There's no license and very little evidence to even support that. So we have to consider what would happen if we give everybody the same dose, essentially, dependent on weight. We do know from pharmacokinetic and pharmacodynamic studies that the DOACs and their actions are very closely related, and their activity is very closely related to the plasma concentrations that we are able to achieve, as well as to a greater or lesser extent the volume of distribution for each of the drugs as well. And lastly, knowing what we know about increased BMI patients, we know that they could have a larger or smaller, depending on the size of patient, the volume of distribution. So theoretically, there is a risk of relative underdosing or overdosing, depending on the patient's weight and the volume of distribution. So looking back, this is a picture of my gym. That's probably me going up in the lift, as you can see. But what we're talking a little bit about is obesity to start off with. And obesity across the UK and nationally and internationally is a big issue for us. Because Raz and I both work in Wales, and because we could find the figures more easily than anywhere else, to be honest, we're just going to have a quick overview of what it is like in Wales. So the last big survey we had in Wales was 2019, when the Welsh government here did a survey, a health survey. 61% of our population here in Wales is classed as overweight, with 25% of our population being classed as obese, following the WHO definition, which is a BMI greater than 30. So within Wales, that's roughly 600,000 adults are classed to be with a BMI greater than 30. Why is that an issue? Well, we do know from lots of different studies that actual increased BMI is an independent risk factor for having a VTE or a recurrent VTE, with about 25% of all VTEs being linked directly to obesity, and then increasing the risk of a recurrent VTE by 2 to 3 times in some patients. So where are we? What evidence have we got to support our actions? What's the history behind why we're doing and why we chose to do it? And as Raz said, why did we set up a regional service to monitor these levels? I take you back to 2016. We have the ISTH recommendations. And the recommendations from the ISTH, if you said you had a patient over 120 kilos, then at that point, ISTH were suggesting doing both peak and trough levels. If these levels fell within the expected range, and I think there is some debate about what we would expect the range to be, but they're suggesting then you would then continue the DOACs. If they were below the range, then at that point, ISTH were recommending, okay, well, you need to switch to a VKA rather than adjusting the dose, which takes us back to our first slide about not just increasing the dose of DOACs just because you don't get the level that you were perhaps expecting. So where did this evidence come from? What evidence have we got? And as we go through, this is very Cardiff-centric type of presentation we're going to do. And the reason I'm saying that is that the DOAC of choice that we use within Cardiff and Vale is the Pixaban, and that's what we have most experience of, although the labs across Wales are now set up to do all DOAC levels. The Pixaban is the primary one that we'll be looking at today. So specifically looking at the use of a Pixaban in an obese patient, we have to look at what trials we had available. So we look at the trials that we have available for VTE patients with a Pixaban, Amplify, Aristotle, and you'll notice there that they had relatively small numbers of patients over 100 kilos, let alone when we get to the 120 plus kilo patients, which we'll be discussing later on. So looking very more closely at the Amplify study, if you notice, only 5% of patients within the Amplify study itself have a weight greater than 120 kilos. And the mean body weight there was 84 kilos. So when we're talking about the ISTH recommendation of doing levels at 120 kilos, you can see that maybe the levels that were suggested were different than we might see now for us. So going forward then, what we wanted to do within Cardiff and Vale is look at, okay, what evidence have we got for our practice? Having just set up this service, we were following the ISTH guidelines to do peak and trough levels for everyone over 120 kilos for venous thromboembolism. Various other post hoc analysis of the Amplify study had already told us that there was no difference in exposure between high and low body weight groups. But again, they were looking at very small numbers of patients, relatively over 120 kilos, for example. And in terms of the follow-up, there was only a follow-up for 30 days in the post hoc analysis. What we were keen to see is a longer follow-up for our patients. What happened over time when we got through the acute phase of VTE and maybe put them on the reduced dose of Apixaban 2.5, would that be enough then to prevent them having a recurrent VTE event, for example? So what we did at the time is we looked at all patients who had levels coming into our labs And I've acknowledged these, my colleagues later on from across the whole of South Wales, because it wasn't just Cardiff, it was other centres in South Wales that all fed into our labs. So we have results not only from Cardiff and Vale, but from our neighbouring health boards as well. But looking specifically at those patients over 120 kilos, but we were very keen in looking at, hey, we got a level, but we also want to see what happened to the patient as well. We looked at 5 milligram and 2.5 milligram at the time. And then we went up to 2021, beginning of 2021, I should say. We had 6 months follow-up for all our VTE patients on 5 milligram, and then we had 1 year follow-up for all our 2.5 patients. To give you an idea of our patient population compared to the Amplify, which I've just described, in Amplify, the average, or the median weight, I should say, was 84 kilos. Our median weight was 133 kilos for the 5 milligram and 140 kilos. So we were looking at a much bigger population. And again, also our BMIs were larger as well. So as the ISTH guidance at the time, we did peak and trough levels. And what we were able to demonstrate for all our patients over 120 kilos with a diagnosis of venous thromboembolism for both the 5 and the 2.5 milligram doses, all of the levels that we saw in our patients were above the 5th centile. So we didn't have a signal at all there that these patients might be having lower levels because of a larger volume of distribution. We did have 1 recurrence of the patients during the acute phase of the trial that we were running here. The patient had a weight of 140 kilos. They had a level done 14 days before they then went on to develop a venous thromboembolism. Unfortunately, the issue here really wasn't a failure in apixaban. It was the fact that the patient, it was over Christmas time, and the patient decided not to take his apixaban over Christmas time. So in our study, and it very much supported what the ISTH was saying, actually looking at our high body weight patients, VTE patients, what we were seeing is that the apixaban could be safely used. We were achieving levels above the 5th centile of predicted steady state exposure recorded in the SPC, and we weren't seeing recurrence of VTEs. Taking you forward a little bit to 2021. 2021, ISTH updated the guidelines, and which is great for us because it validated a lot of what we had already seen, where ISTH was saying that for patients with BMI greater than 40 or more than 120 milligrams, standard doses of rivaroxaban or apixaban should be used, and not to do peak or trough DOAC levels in these patient groups. I'll point out the fact that ISTH specifically recommends rivaroxaban or apixaban because that is where most of the evidence for these obese patients would sit. At that time, 2021, there was a lot of evidence for rivaroxaban. However, ISTH at that time actually suggested that there was a relative comparative lack of evidence for the use of apixaban in this patient group. As a result of that, what we did, and what I'll show you later on, is that we continued to gather information on our apixaban patients. We had the data and confidence up to 120 kilos. What we didn't know is what's the upper limit? How far can you push the dose without seeing recurrence of VTE, bleeding, or low or high levels, for example? So looking forward then, we extended our data set. So we're now including right up to the start of this year. And what we looked at is apixaban trough levels for all VTE patients with a weight greater than 120 kilos. Bit of a mammoth task, looking at 3,700 odd apixaban levels, but in the end, about 800 levels were for patients with a venous thromboembolism. Specifically then looking at those patients who had an acute VTE event on apixaban, they were put on apixaban 5 milligram BD and they weighed 120 kilos or more. We had 73 patients with 76 levels, a split of 31 females to 42, Our median age was quite young comparative to what we might be seeing in some of the AF work we're going to be doing later on. So just to keep that in mind when we're talking about levels. For our VTE population, the median age was 54, our youngest patient being 25 and going up to 87. So a big age range as well. With our median weight being 138 kilos. Again, ranges from 121, our heaviest patient in this study was 177 kilos. What's important later on, and we'll talk about renal function a little bit later, which I think may key into some of the talks you'll be maybe listening in later on today, is looking at the renal function for these patients and the possibility of hyperfiltration, but we'll touch on that in a little later on. But suffice to say that all of our patients had very good renal function. So the concern was potentially there could be extra clearance involved with that. These are our results. These are all trough levels. And just to orientate you on the slide, I know it's quite a busy slide. The bottom orange, orange, I'm guessing is a yellowy goldy color. Let's go for that, shall we? A yellowy goldy color there demonstrates the 95th centile trough results. The median, which is the gray line that runs halfway between that and the top line, that's the median trough. And then the top line there is the 95th centile. So I think so what you can see from this is that we had a number of, majority of our patients were within the 5th to the 95th. And we only had one patient who had a low level, which if you can see my cursor is this gentleman here. On retesting, it was here. This gentleman had a low level because they weren't taking his medication. The rest of the time, all of our results were above the 5th centile of results, which is the bottom line here. Yeah. So that filled us with confidence that what we saw initially on our initial study was carried forward, knowing that we were actually able to achieve, even on weights of up to 177 kilos, we were getting levels that were within the predicted steady state exposure for apixaban. We then took this forward to look at our prevention patients, those patients on the 2.5 milligram dose. Some of these patients were the 5 milligram patients that we then followed through for longer. In this case, we had 31 levels from 25 patients. Again, the median weight 134 kilos, so slightly less than that. But the range is 120 to 170, so still got a big range of weights. And again, similarly, what we're seeing is that the vast majority of bar one patient, who again on retesting was actually above the 5th centile, all achieved levels that were above the 5th centile. So again, filling us with confidence that actually you can use apixaban in their normal licensed doses for patients who are even greater than 120 kilos. So overall then, if we are talking about our experience of VTE patients weighing more than 120 kilos, what we're suggesting here is that for those patients on 5 milligram BD, 98% of our patients had levels above the 5th centile. One patient who I explained earlier on had a low level, but that's because they weren't actually physically taking the apixaban at the time. For the 2.5, again, very, very positive from our point of view and validated a lot what we were doing here and validated our work from earlier on, is that when we're looking at the 2.5 milligram dose, 100% of our patients had levels above the 5th centile. So again, from our perspective, what did we learn from this? The ISTH recommendations, were we able to say, yes, we agree with the ISTH recommendation, we have evidence to support it? Yes, and in our minds, and when we presented this at ISTH a few years ago, it actually validated a lot of what the limited data we had around apixaban was. So yes, it fulfills what the ISTH recommendation was suggesting, and it added to some of that evidence as well. In terms of our practice, how did this change our practice? From going through this, we've now stopped doing levels up to 150 kilos. Now, arguably, and I think Raz and I were going to have discussions about this, is that we're kind of confident up to 160, but maybe not to 170. So definitely from our perspective, we are comfortable in our centres, and when we provide advice to both our primary care colleagues, but also our colleagues across Wales, we would suggest that for VTE patients, you don't need to do a level unless you're over 160 kilos. But we're still looking for more evidence for the larger population over 170 kilos, for example. And the eagle-eyed amongst you would have said, well, hang on a minute, you didn't do any peak levels, and why didn't you do that? Well, when we looked at our original study data, we didn't see any benefits in doing the peak levels. Peaks obviously are mostly attributed to the absorption of the drug. What we are concerned about is the accumulation of the drug over time, and that's why the troughs gives us a much better idea of what's happening with the actual levels in the patient. Also, this study encompasses part of the pandemic as well, where getting levels was incredibly difficult, let alone trying to get patients in for the same day to get a peak and a trough, which was very, very difficult to do. Also, just doing a trough level made it much easier for our primary care colleagues. So when we're talking about levels going forward, we would certainly recommend only doing trough levels unless you have concerns about absorption. I talked a little bit earlier on about why we put that figure up for you about the renal impairment. Why were we concerned about that? What we do know, and we have some evidence for, is that for certain DOACs, such as edoxaban, for example, there is concern about the potential for hyperfiltrating these drugs. For those patients with very good very good renal function, actually clearing the drug too quickly. I believe it's still in the edoxaban FDA advice regarding the use of edoxaban in those patients with creatinine clearance greater than 90. Now, when we looked at our data initially, we saw that all of our patients had very good renal function. What we weren't clear on is what was the best way of first of all, measuring that renal function. Should we use actual weight? Should we use ideal body weight? Or should we use corrected body weight for our patients? But also what the effect would be of these very high relative clearance of these drugs. And as you know, apixaban is perhaps the least renally cleared DOAC of all. So we were hoping then and looking at the data thinking, well, actually, we don't imagine there is a problem, but we need to be sure. This graph demonstrates then the levels of apixaban patients on 5 milligram BD with a BMI greater than 40, and it plots the levels against the creatinine clearance using actual body weight in this particular graph. Although if you were to use ideal body weight or corrected body weight, you'll see a very similar graph. In all cases, what we saw is there is a relationship between increased creatinine clearance and the reduction in the apixaban trough levels. And it's consistent, and it doesn't matter which you used in terms of the weight that you used. But in all cases, what we saw is that the levels that we were able to achieve in these patients were all above the 5th centile of a predicted steady state exposure. So that's great. We know then we have the guidance from ISCH 2016-2021 for those patients above 120 kilos. What happens if you've got a small patient, a small VTE patient or a small AF patient? What do you do? Can we use DOACs with the same level of confidence that we have now with the higher body weight population? What we do know is that those patients with a lower body weight, this is for apixaban specifically, those patients with a body weight of less than 50 kilos, from the data that the company provides, have approximately 30% higher drug exposure than someone who's more than 50 kilos. So there's a signal perhaps there that, okay, well, we need to look into this in a bit more detail. We do know as well from other studies that low body weight of patients may increase the risk of bleeding compared to normal body weights. potentially due to accumulation of the drug. So what have we got to guide us in these patients? What guidelines have we got? What consensus documents have we got? Unfortunately, at the moment, there's a real lack of national or international guidelines, and there is very little consensus among those guidelines. Some guidelines are actually recommending you wouldn't use DOACs in patients less than 50 kilos still. So again, what we're trying to find out is, have we got any evidence to support the use for ourselves, but also what can we learn from our experience that we can then share in forums such as this. What guidance there is, this is from the EHRA, for example, and you will notice at the end of the scale here with body weight less than 50 kilos, it's then considering plasma concentration levels, or indeed considering a VKA. So again, from that, you can see this is the EHR, this is the latest one in 2021. So even in 2021, there's still some debate as to whether or not DOACs can be safely used in these patient groups of less than 50 kilos. Fortunately, we're beginning to get more and more evidence now. So there are a number of meta-analysis and studies that have looked at the safety of the use of DOACs and apixaban and all the other DOACs as well in this patient group as well. So we're beginning to get a lot more information to support their use as well. When we looked at our data set we had available, relatively small numbers of VTE patients less than 50 kilos during the initial treatment phase on 5BD, 19 levels and 14 patients. If you look at the age of these patients, 83. So that's the median age, much older than our original VTE population that we were initially looking at, with the higher body weight groups. I guess what you would kind of expect that older people tend to be smaller in size, for example. And if you look at the renal function as well, that the median renal function is much lower than the hundreds or 200s that we were seeing previously from our larger VTE population. And this, I think, graph shows a very different picture. What you can see again, the bottom dotted line is the 5th centile trough, the grey line in the middle is the median, and then above that you've got the brown line is the 95th centile. So what we actually saw in our patient population is about half of our patients who were less than 50 kilos on treatment dose of 5BD of apixaban actually had levels above the 95th centile. So in this particular patient population group, we saw that these patients were actually accumulating the drug more than the older population would have been. Sorry, the younger population would have been. We then looked at the 2.5 milligram data. So are we seeing similar levels of accumulation once we reduce the dose down? So again, not big patient numbers that we have, only 13 patients for 18 levels, 82 as a median age. So again, a more elderly population with this very similar renal function than our 5 milligram population we saw. And again, we see a very similar picture with these patients, that a number of these patients, about half of our patients, again, have some evidence that we're actually accumulating the drug. So when we look at our overall results, and this is not levels, or this is not data that we've actually published yet, so we do need to go and look through outcomes for these patients. But as I said, for our 5 milligram population, for those patients weighing less than 50 kilos, about half of our patients had a level above the 95th centile. Of those, about 60% of those patients had some degree of renal impairment. So we know that their renal function was less than 30 mils per minute. So these are small patients with renal impairment, and as you may surmise from that, the levels would be perhaps higher because of those two things coming together. Interestingly though, if you look at the median trough levels, the median trough was 157, which is within the predicted steady state of someone on 5BD, according to the SPC, although the range was very large, as you can see. Looking at the 2.5 milligram population, 60% had levels more than the 95th centile. So we know that even reducing the dose, we are seeing higher levels. The medium trough for this patient group was actually within the range of a 5 milligram BD dose. So what do we know in conclusion? In low body weight patients, what we've seen from our results for apixaban specifically is that for those patients with VTEs less than 50 kilos, they may accumulate apixaban, especially if they have some degree of renal impairment. Due to the small numbers, it's quite difficult to draw any generalized conclusions. But for our practice, I think we would still recommend continuing, if you are going to be using a DOAC, monitoring those levels for VTE treatment for those patients less than 50 kilos. And then the question then becomes, I think this is probably something that, one academic question that I think we need to maybe think about is, if we are going to be using DOACs in these patient groups, should we be dose adjusting these patients, particularly in view of renal impairment as well? So that's a very brief overview of what we've been able to do in terms of venous thromboembolism treatment. What I was keen to do now is to move on to atrial fibrillation. And can we take the lessons that we have learned from venous thromboembolism population and move them forward into an AF population group? Why is this important? Well, as you know, AF, the vast majority of patients on anticoagulants and DOACs in particular are going to be for stroke prevention in the presence of atrial fibrillation. So again, looking at a Wales-centric data set, what we're looking at now is, this is from April of this year. So literally as of the 1st of April this year, we had about 85,000 patients in Wales with a diagnosis of atrial fibrillation. If you recall earlier on, we said in Wales there are about 600,000 patients who were clinically obese, according to WHO definition. So a large number of our atrial fibrillation patients are going to be anticoagulated. They're going to be obese as well. So in terms of what we give them and what we should be monitoring, and have we got the level of confidence to say, yes, you can use the DOACs in this patient group for both large and small patients? What we do know within Wales, from that 85,000, we know that about 83% of that total population will be receiving anticoagulation. Now, some of that 85,000 might be CHA2DS2-VASc 0, CHA2DS2-VASc 1, so they may not be appropriate. They are anticoagulated. But the vast majority within Wales, at least, and I know a lot of the work has been done in the UK as well, of the patients with a high stroke risk would be anticoagulated. What do we treat these patients with? Again, very similar. I'm sure if you pick the data from any CCG or anywhere else within the UK or internationally, you'll see that a lot of patients are now treated with anticoagulants, and the vast majority are actually going to be on the DOACs rather than warfarin. Within Wales, we've only got a population of about less than 10% of our atrial fibrillation patients are going to be on warfarin. Very small numbers. So there might be some overweight patients that are historically still on the warfarin, for example. But if you look at the DOACs and the use of DOACs, this is all DOACs, then 73% of the anticoagulated patients are going to be on DOAC. So again, very pertinent in terms of knowing what to do with these high and low body weight AF patients as well. And this is something that's been evolving over time. Ever since the DOACs have been coming in, this graph demonstrates the change in anticoagulation prescribing for atrial fibrillation across Wales from April 2019 to October 23. And if you were to extrapolate the graph out, it just keeps growing as well. So the numbers of warfarin patients are going down, and the numbers of DOAC prescribing is going up. And we know that the average body weight for patients is also going up as well. So the number one question is, okay, well, you've shown me the data for VTE. We know we have guidance for VTE. Can we just extrapolate the data that we have for VTE across to our atrial fibrillation patients? Well, looking at the guidelines that we do have, so we look at the ISTH guidelines, for example. If you look at the ISTH guidelines of 2021, they're specifically only venous thromboembolism. The guidelines don't even mention atrial fibrillation. Now, is the assumption here that we can just say, okay, well, venous thromboembolism we know is fine, therefore AF has got to be fine because we're using the same drug? Or are there differences within the patient populations? Well, clearly there are differences because our atrial fibrillation patients tend to be older as a class. They have to have more, they tend to be having more pre-existing comorbidities. And as a class of people and a group of people, the elderly atrial fibrillation patients may well have, on average, a reduced renal function, which becomes very important when we think about how patients get rid of the DOACs from their systems. So what guidelines do we have? So this is from the EHRA Practical Guide 2021. They're suggesting that we should either use apixaban or edoxaban out of preference because they have found in their studies and other studies that have been, the drug concentrations didn't differ in low body weight patients from the clinical trials. And they're suggesting that if you have those patients with a low body weight, less than 60 kilos, then you should either be using apixaban or edoxaban. What we were very keen is, okay, well, we have the data set available to us. We have a large number of atrial fibrillation patients. So can we use the same methodology, the same learning tools that we learned for our VTE patients to then look at our AF populations? So what we then looked at is all the trough levels for AF population this time. Again, similarly with weight more than 120 kilos or less than 50 kilos, for example. Now, I'm going to pop this slide up here just to demonstrate what is important when we're talking about the levels, because as a lot of you will know, and apologies if you know this already, but all of the levels were taken from the various trials for the DOACs. Specifically, we're looking at the apixaban trial data here, and the levels are derived from things like the Aristotle trial, for example, or the amplified trial, for example, depending when you're talking about AF or VTE, for example. Within that patient group, they looked at levels, but we have to assume then that we need to know what those patients look like and that patient population look like in that particular study. And can we then apply it to our general population? As I've already explained to you, the VTE population that we have is perhaps different than the trial population, where only 5% of patients were above 120. And we all know we have a lot more patients than that who are diagnosed with venous thromboembolism, for example. So there are differences, and when we're specifically looking at the differences to VTE and AF, you'll notice a big difference in the 5th centile, the 95th centile, and the median. So if you look, for example, at the 5 milligram twice daily for prevention of non-valvular atrial fibrillation, the 5th centile would be 41 nanograms per mil, the median would be 103, and the 95th centile would be 230. If you were to look at the same dose in the VTE trials, the levels they were achieving, the 95th centile, 177, so lower, 63 was the median, and 22 was the lowest of the 5th centile. So there are differences. So when we put up some more graphs now for atrial fibrillation, the levels will change. And that becomes important when we talk about some of our results. You know, we had to scratch our head a bit and think about why we got the results that we did. So looking at those patients with atrial fibrillation with a weight of more than 120 kilos, bigger population, we had 138 patients, majority were male, median age is 64, which becomes important when we talk about later on. Median weight about 140 kilos, but up to 240 kilo patients we had with atrial fibrillation. And again, the creatinine clearance, very good, over 148 mils per minute. So this is again another level chart. what you will see from this is that no levels were above the 95th centile. Majority of them were between the 5th and the 95th, although there was a population of levels that were below the 5th centile of predicted steady state according to the SPC, which is the ones we've highlighted here. So when we're talking about this patient population, if you look at our patient population compared to the trial population, our population were much younger. So if we look at a similar population in terms of age, that would have been the VTE trough levels. So if we superimpose the VTE trough levels on this graph, which is for atrial fibrillation, you'll notice that most of the levels are now above the 5th centile. And that's probably more representative of our patient groups in terms of their renal function, in terms of their weight, etc. So these patients with atrial fibrillation tended to be younger, they tended to be bigger, and they tend to have better renal function than those patients you would have seen in the trials, which is where the data was derived from. So I think a take-home message that we've certainly learned is that when you're interpreting levels, you have to think about not just necessarily does it fit within that level, but if it doesn't, why? So are there interacting drugs, which we'll talk about later on? Are there renal impairment? Is the patient bigger or smaller than you would expect to say? So it's a bit of a dark art sometimes interpreting levels, but certainly if you look at some of our results, that would seem to indicate that well, actually maybe the levels we're using for these obese patients with atrial fibrillation, we may need to look at what levels we're actually using to mark that against. As a comparator, in the Aristotle trial, the median age was 70 and our median weight was 82. So if you go back to look at our patient group, we had a younger population, 64, for example, and a much higher weight than those levels were derived from in the SPC, for example. So what we were keen to look at is, okay, well, we have lots of patients who are on 2.5 long-term for AF. So these are 2.5 milligram patients. Looking again, we had 56 patients, 81 levels. Majority of our smaller atrial fibrillation patients were women with an average age of 85 and a reduced renal impairment as well. So down to 34 mils per minute as an average. What we began to see here is the impact more of renal impairment as well as potential drug interactions as well. So again, when you're interpreting levels, we have to start thinking about, okay, well, why is it so high? So if we were to look at this group of patients who had a level above the 95th centile trough, all of those bar one had either poor renal function, down to about practically about 20 to 15 mil per minute in some cases, or were in interacting medications. Like, for example, there's a couple of patients on itraconazole within that group. The rest of the group were actually below the 95th centile for our results. So when you're looking at levels, and what we found is that when you look at levels, you have to think about what's caused them. But certainly from our point of view, we have confidence that we can use apixaban 2.5 milligram in atrial fibrillation patients weighing less than 50 kilos, as long as they have preserved renal function and no drug interactions. So in conclusion, and then I will stop talking, and then we're more than happy to answer any questions, and I'm sure Raz will jump in. What we found from our practice for looking at specifically the use of apixaban for VTE patients more than 120 kilos, we stop measuring levels unless they're about 160, 170 kilos. For those patients with less than 50 kilos with VTE, there's a signal that we feel that we are not confident to say yes or no on, is that there may well be a signal there's accumulation in that patient group. For those patients with atrial fibrillation, more than 120 kilos, we're seeing a younger population relative to the trials. So some of the levels are a little bit low, but again, it's not something that we think might be clinically significant. And I'll come on to that in our very last slide. And then with those patients who are very small, who are on the lower dose of apixaban for atrial fibrillation, really the big determinant factor is renal impairment or potential drug interactions. And where we're going now is, okay, well, we've got the levels, but the big question is, we've got a lot of levels, but do the levels equate to clinical outcomes for our patients? So what we're now doing here is adjudicating all of our results, looking at all of our patients, and then for the number of years follow-up, we're then looking to see whether they atrial fibrillation patients are a high extremes of body weight, have increased risk of bleeding, or they have increased risk of strokes, or a VTE population, bleeding or recurrence rates as well. And then very lastly, I'd just like to thank everybody involved in our service, but also our colleagues from across South Wales who helped with all of this as well.
That was fantastic. Thank you very much, Tristan. We're going to go to the chat function. And firstly, I'm not sure if we can stop sharing the screen and just get...
I don't know if you want to look at the Q&A, because as well as sort of topping our best ever numbers attending, we also are topping the best ever number of questions submitted.
Okay.
The chat's been fantastic with loads of questions, but also people responding. We have a large number of questions in the Q&A. If you want to look through some of those, I'm happy to go through it with you if you like.
Yeah, do you want to help us navigate that? Tristan does all the work here, as you can probably tell. I just sort of put my name to everything. How do we get out of this screen while we're yeah?
If you stop sharing,
we'll stop sharing, and I've clicked a button, so I haven't really helped Tristan here. Look, there we go. Fantastic. We're over to you, Joe.
Great. Well, the question I can see, so in an obese pregnant lady, do we need to check the levels of DOAC, and is there any variation due to the physiological changes?
So this is a great question, right up until the point that you said pregnant. And the reason for that is we don't use DOACs in pregnant patients, okay, because they cross the placenta. And so if you've got a patient who's on a DOAC, we counsel them not to get pregnant. But we also counsel them that if they do fall pregnant, to contact us as soon as possible, and we switch them to low molecular weight heparin. So this is not a question that's of clinical relevance. And then when they're breastfeeding, we know that the DOACs get into breast milk, so we continue with the low molecular weight heparin. We don't stop women breastfeeding. So yeah, I don't think we should answer that question for a pregnant patient. We would strongly encourage you to put them onto low molecular weight heparin.
Okay, thank you so much. That's my lack of knowledge, isn't it?
No, it's not you. We get asked that question quite regularly. It's interesting because there's a concern about pregnancy and volumes of distribution. It's not you. I think it's really important that the message gets across to our audience. Don't use DOACs in pregnancy. And if you do, join the ICH registry on DOACs in pregnancy and report any concerns. Yes.
Good morning from Wales here. Fantastic presentation. They have a patient 180 kilograms, and they're asking, do they need to check the level or use warfarin for now until further evidence?
What's the indication? That would be the first question.
So let's say it's VTE.
So VTE, I think we're comfortable up to about 170, 180. I would say yes, I would do a trough level, but only do a trough level once they're at steady state. I don't think there's unless there's evidence that, or you suspect there might be a problem with absorption, the peak's not going to tell you anything. But I think from our experience, we haven't got enough evidence at 180 kilos, just on the cusp of probably where we're not totally confident for.
And I think it's really important that we clarify why we presented a PIC-SPAM data. There's lots of great data UK-wise and sort of globally that Tristan touched on for rivaroxaban. And across the UK, the two DOACs that are most commonly prescribed are rivaroxaban and apixaban. There's a little bit of edoxaban, but we don't have any good evidence for edoxaban and extremes of body weight. So all of the evidence in the ICH recommendations talk about apixaban.
and rivaroxaban.
Perfect, thank you. Question from somebody I know well. So thank you very much. Really interesting data. Based on your results on apixaban in low body weight, how do you manage the 10 milligram BD 7 days initial dosing for apixaban? This dose often concerns in everyone in the low body weight, low creatinine clearance population.
Yeah, so we had a case yesterday. I personally, particularly if they've got low poor renal function, I think so this is not evidence-based, this is an opinion. We go with low molecular weight heparin initially. I think you've got to take that 10 milligram BD dose out. That's high. We've done a few patients, we haven't presented them. They've got levels over 300. And there's another question that's just popped up about how long you need to wait to do a level. You've got to wait to steady state. So we're looking at 3 to 5 doses. When we're loading a patient with apixaban, it's 7 days. You know, do you wait 3 or 4 days and then say, well, they're a bit overcooked? Yeah, I think go in with low molecular weight heparin. We saw that in the pediatric studies with Einstein Jr. with rivaroxaban. And please, I'm not saying that children are little adults or anything, but they went with they took out the 15 milligrams BD for 3 weeks, and they actually give the patients, I think it's 5 days of low molecular weight heparin before they give the pediatric dose. And I think in a little old lady who's low body weight, bit of renal impairment, some low molecular weight heparin, and then a DOAC. And then we get into the question I'm going to ask Tristan, do you go with 5 milligrams? So say they weigh 45 kilos. Do you give them, after a week of low molecular weight heparin, do you give them 5 milligrams twice a day? Or somebody asked me, yes, they shouldn't go with 2.5 milligrams twice a day. Put you on the spot.
Yeah, thanks for that. Yeah, cheers. I think it depends very much on what level of renal impairment they have. So if you're small, elderly, and poor renal impairment, then I think you could make a case for actually reducing the dose, but doing a level, and you must have facility to do the level, particularly as we know that if for VTs, that's the highest risk of having a recurrence. If you can't do a level, then it may be more sensible to continue the low molecular weight heparin for a longer period of time before switching, especially for the first month, I would suggest, before you switch them across.
Yeah, I think so. Yeah.
Okay, thank you. Another one, I think it may be linked, but your thoughts on giving apixaban as OD dosing and renal impairment, e.g. creatinine?
No.
No.
It's like we're telepathic. Just don't do it. No, the half-life of these drugs is 12 hours. It might extend out in renal impairment, but we just don't know how long it extends. The reason we do troughs is it's all very well doing a peak and saying you've got a measurable level. Our concern was that there wasn't going to be any drug present at 12 hours. That's why we went to troughs. And so we're confident with that. We see very high levels at 12 hours in renal impairment. There's some dialysis data in patients with end-stage renal failure. They give the apixaban twice a day. I don't think you should be going to daily dosing.
Okay, thank you. Now, this question, excuse my ignorance because I don't have a medical background, but there are 2 parts. I'm not sure, well, a bit more advanced than I am. So bariatric surgery, please can we discuss the evidence and causations for use of DOAC or pre-post bariatric surgery? And the second part of that was, whilst where that's person is, they don't recommend adjusting dose according to high weight. What about bleeding with high levels on standard dose? Would you dose reduce according to the level?
Okay, so 3 or 4 questions in there. The bariatric data is probably strongest for rivaroxaban, and it's being used for thromboprophylaxis. And the data that I've seen has both levels and outcomes that shows that you can use rivaroxaban thromboprophylaxis for bariatric surgery. So as far as I'm aware, that's evidence-based and supported. So I think we have to be careful here. Tristan made a really important point about levels. So we look at the SPC for apixaban, which has predicted steady state levels. And if you look at them for VTE and AF, if you look at AF and then you look at our data, it suggests that our AF patients have low levels, but our VTE patients have good levels when they're heavy. But you've got to understand what the age of that group are. Our AF patients who are heavy tend to be younger, whereas the AF patients in the trials tend to be lower body weight, but older. And so their levels are different. So I think you have to be really careful how you look at levels. And Tristan's point at the end, his final slide which was, we're looking at outcomes, recurrent rates of thrombosis and bleeding. So I think before you start just looking at a level and then say, I'm going to change, you have to understand why those levels are high. We tend to repeat all our high levels, unexpected levels. But I think it's a valid point if levels are high. So if I have go back to you, if you've got a patient, say they're at 6 weeks or even 3 months, and their apixaban levels are 200-300 at trough, and they're on 5 BD, what would you do with the apixaban?
I mean, I think it you know, if on repeat they're still high, you could clinically make that decision. Okay, well, we know the levels are high on 2.5. We'll reduce them to 2.5, repeat the levels, and then if the levels on 2.5 are equivalent to what you would be expected to see on 5, you're then dosing the patient according to the expected trough levels, even though you're dosing at a lower with a lower dosage.
And you do that for AF,
Yeah,
as well. Yeah, and that's one of the reasons why the AF license suggests lowering the dose, because you're trying to still achieve a therapeutic level.
Yeah.
In terms of efficacy. Yeah.
Okay, I think we've time for one more question. This one, would you use edoxaban for low body weight acute VT patients, licensed 30 milligram dose for patients under 60 kilograms, rather than using unlicensed apixaban dose? Opinion.
So this phrase of licensing, there's nothing about licensing. So apixaban's licensed. This thing about less than 60 kilos, it's not 60 kilos I'm worried about. It's not 50 kilos I'm worried about. It's these patients who are 35, 40, 45 kilos. What are your thoughts?
I mean, in all honesty, I can't give you the answer to that because we're not an edoxaban centre, so we haven't got the experience here. Other centres use edoxaban and do levels for edoxaban and are very comfortable using it or not. I couldn't comment personally. For our point of view, if we did have an edoxaban patient, I would probably switch it to apixaban because we have more confidence, and it's not specifically because you know, we're certainly not paid by the company because the company doesn't exist anymore, but it's more from our personal point of view in terms of what we've done, and it's generic.
It's generic.
So from our experience, we would tend to switch a lot of patients who are at the cusp or weight, and where we didn't have experience, like the bigger triumphant patients, for example, we don't have any experience of here personally. So we personally use what we are comfortable with here, but that's not based on any recommendation to say you must use apixaban over anything else.
And I'm just going to quickly jump in. There's a question here about, can we give DOACs post-op for a post-op PE? If you can give low molecular weight heparin because you're not worried about bleeding post-op, then you can give a DOAC. I think that's the way to interpret that question.
Okay, we have really run out of time, but what I would like to say to everybody is we are so fortunate. At 11:45 there is a roundtable meeting where both Raza and Tristan will be joining Bex and Alexandra, who are in the next session, to take more questions in an informal roundtable session. So that's at 11:45. Do join that, because it will be opportunity to chat, discuss face to face in those small groups. Places are limited, but I think this one will be exceptionally popular. But for now, thank you so much, Raza and Tristan. Fantastic.
Thanks, Tristan. And Joe, as always, thank you so much for the invite. Thank you.
But thank you.
Take care.
Bye-bye.